Hello friends, welcome to my channel. Hope you are doing good. I am Dr. Prashant and today we are going to talk about plasma cell disorder. What are the normal plasma cells, abnormal plasma cells, what is multiple myeloma, its etiopathogenesis, the diagnostic criteria for multiple myeloma, prognostic marker of multiple myeloma, and plasma cell leukemia. So let's start. So before going to plasma cell disorder, let's talk about plasma cell. So what is plasma cell? So plasma cell is differentiated B lymphocyte. So plasma cell is differentiated B lymphocyte. So how does the plasma cell gets differentiated? So it starts from B lymphocyte. B lymphocytes gets converted into reactive B lymphocyte, which then converts into plasmablast, then into proplasmacyte, and finally gets differentiated into plasmacyte or plasma cells. So this is how B lymphocyte gets differentiated into plasma cell. So what is the size of plasma cell? The size of plasma cell is 14 to 20 micrometer. So the size of plasma cell is 14 to 20 micrometer. How does a normal plasma cell look like? So this is a normal plasma cell. So you see a small round oval cell. So this is an oval round cell. It has an eccentric nucleus. So the nucleus is pushed to the one side. Nucleus is pushed to one side, and inside the nucleus you will see radially arranged chromatin fibers. So these are radially arranged chromatin fibers, which looks like a clock face, or it gives a cartwheel appearance. Now around the nucleus there is a clear space which is known as perinuclear off. This perinuclear off is due to Golgi bodies. And the cytoplasm, look at the cytoplasm. Cytoplasm is blue in color, and this is due to basophilic. So basophilic cytoplasm is due to rough endoplasmic reticulum. Now coming to abnormal plasma cell. Abnormal plasma cell, they have hyperchromatic nuclei. So they have hyperchromatic nuclei and there is no perinuclear off. So abnormal plasma cell is more basophilic. Now coming to multiple myeloma. Multiple myeloma is a plasma cell neoplasm which is characterized by involvement of skeleton at multiple sites. So they are multifocal monoclonal proliferation of plasma cell. So they are multifocal monoclonal proliferation of plasma cell, which gives a fried egg appearance. So it is characterized by fried egg appearance. So it is mainly seen in 40 to 70 years of age group, and males are more commonly affected than females. The most common presentation is bony lytic lesion. So bone undergoes lysis, and this causes weak bone, which results in back pain. So there will be backache. Multiple myeloma, it also presents with normochromic normocytic anemia. So multiple myeloma is associated with normochromic normocytic anemia. So what are the monoclonal? So what are the monoclonal protein immunoglobulin that are synthesized in multiple myeloma? So most common immunoglobulin is immunoglobulin G, IgG, then IgA, then IgM, then IgD, and the least common is IgE. So IgE is the least common. In multiple myeloma, there will be excess of M protein. There will be excess of M protein. These M proteins are monoclonal light chain. Therefore, excess of M protein in multiple myeloma, it goes to the urine. when it comes to the urine, it has got two possibilities. It can either form Benzone protein or it can get deposited in renal parenchyma. This Benzone protein is a light chain immunoglobulin, and when you hit this protein up to 50 degrees centigrade, it forms clot. When you continue hitting up to 100 degrees centigrade, it will become liquid again. So when you hit up to 50 degrees centigrade, it forms clot. When you further hit it, when you continue hitting it up to 100 degrees centigrade, it becomes liquid again. So when the light chain gets deposited in renal parenchyma, it will form primary amyloidosis. So it will form AL type of amyloidosis, that is primary amyloidosis. So primary amyloidosis is seen in multiple myeloma. Now, most common cause of renal failure in multiple myeloma is light chain deposition and hypercalcemia, but light chain deposition is more common than hypercalcemia. Now we'll talk about molecular feature of neoplastic plasma cell. Molecular feature of neoplastic plasma cell. So B cell forms abnormal neoplastic plasma cell under the influence of excess of interleukin 6, results in the pathogenesis of multiple myeloma. Now once the neoplastic plasma cell is formed, it releases MIP-1 kappa protein. This is macrophage inflammatory protein 1 kappa. This MIP-1 kappa gene, it causes overexpression of rank ligand. This rank ligand causes activation of osteoclast. Osteoclasts are modified macrophages of bone marrow. So once the osteoclasts are activated, they cause bone lysis. So they cause bone eating, which results in hypercalcemia. This MIP-1K protein, it also causes activation of WNT pathway. So once the WNT pathway gets activated, this will cause inhibition of osteoblast. Osteoblasts are bone forming cells, so they will inhibit the osteoblast cell, and the result will be serum alkaline phosphate will be normal. So remember, whenever there is activation of osteoblast, there will be increase in serum alkaline phosphate. But when there is inhibition of osteoblast, the serum alkaline phosphatase will be normal. So osteoblast activity is measured by serum alkaline phosphate. So in case of traumatic bone fracture, Brown's tumor and Paget's disease, the serum alkaline phosphatase level will be high because there will be activation of osteoblast. So in case of traumatic fracture of the bone, Brown's tumor and Paget's disease, there will be increase in serum alkaline phosphatase due to the activation of osteoblast. Now what happens if there is excess of deposition of M protein in plasma cell? So when M protein in plasma cell is in excess, it will form either inclusions in the cells or they will form Mott cells or flame cells. So when M protein is deposited in cytoplasm, that is endoplasmic reticulum, it is known as Russell's bodies. So when M protein is deposited in cytoplasm and the endoplasmic reticulum, it is known as Russell's bodies. Similarly, when the protein gets deposited in the nucleus, it is known as Dutcher's bodies. So the nuclear deposition of M protein is Ducher's bodies. When there is bluish cluster of grape-like basophilic inclusion, it is known as Mott cell or Modular cells. So you see here, there are bluish clusters of grape-like appearance of basophilic inclusions. So these are Mott cells or Modular cells. Here you see M protein with fiery red deposition. This fiery red deposition of M protein is known as flame cells. Now, what is the diagnostic criteria for multiple myeloma? Diagnostic criteria for multiple myeloma. They can be myeloma defining events or they can be active multiple myeloma. So myeloma defining event, it has got three criteria. Clonal plasma cell should be more than 60%. That is, bone marrow plasma cell should be more than 60%. Serum free light chain, that is, involved light chain by uninvolved light chain should be more than 100. So involved light chain means whether the plasma cell is involved or whether the plasma cell is not involved. So the ratio should be more than 100. And the third criteria is MRI. MRI will show more than one focal lesion, and this focal lesion should be more than 5 mm in size. So the lesions should be more than 5 mm in size. So how can you remember this? So there is a mnemonic SLIM, SLIM at 15 mm. So S means 60. So plasma cell should be more than 60%. So bone marrow plasma cells should be more than 60%. Li is the light chain, that is light chain involved by uninvolved. It should be greater than 100. And M for MRI. MRI shows one focal lesion which should be greater than 5 mm in size. So these are myeloma defining events. Now talking about active multiple myeloma. Bone marrow biopsy showing clonal plasma cell should be greater than 10%, and there should be evidence of end organ damage, so which are assessed by CRAB criteria. So what is CRAB criteria? C is hypercalcemia, R is renal failure, A is anemia, and B is bone lytic lesion. So you can remember it easily as they are interrelated with each other. So B is bone lytic lesion. So when there is bone lytic lesion, there will be destruction, there will be damage to precursor cells. So this will result in anemia. This bone lytic lesion will also cause hypercalcemia, and the result of increased calcium in the blood may precipitate renal failure. According to WHO, multiple myeloma can be diagnosed by myeloma defining events with or without CRAB criteria. So any one of the three criteria of myeloma defining events. So we have talked about three criterias of myeloma defining events. So any one of three criterias with or without CRAB criteria can diagnose multiple myeloma. So now, what are the prognostic marker of multiple myeloma? Prognostic marker of multiple myeloma. Beta 2 microglobin is released by abnormal plasma cell. So abnormal plasma cell releases beta 2 microglobin, which is suggestive of tumor overload, and this will suggest a bad prognosis. So beta 2 microglobin is best prognostic marker. So what are the tumor overload markers? The tumor overload markers are C-reactive protein, serum LDH and beta-2 microglobin. So these are tumor overload marker. When these tumor overload markers are high, they will have bad prognosis. Another prognostic marker is cyclin D1. The cyclin D1, so when there is increase in cyclin D1, it is suggestive of good prognosis. So cyclin D1 is suggestive of good prognosis, and it is the best immunohistocompatibility marker of multiple myeloma. So best immunohistocompatibility marker of multiple myeloma is cyclin D1. On performing immunophenotyping, normal plasma cell will have CD marker 38 and CD marker 138 positive. So CD38 positive and CD138 will be positive, CD19 positive and CD20 positive. So normal plasma cell will have all these markers as positive. Multiple myeloma will have CD38 positive and CD138 positive as in case of normal plasma cell, but there will be CD56 will also be positive, whereas CD19 will be negative and CD20 will be negative, where in normal plasma cell CD19 and CD20 were positive. Now we'll discuss on plasma cell leukemia. So what is plasma cell leukemia? So whenever there is a neoplastic plasma cell in the peripheral blood, neoplastic plasma cell in peripheral blood, it is known as plasma cell leukemia. So the most common site is vertebral column, and there is only one diagnostic criteria for plasma cell leukemia, that is absolute plasma cell count should be more than 2 into 10 to the power 9 per liter, or peripheral blood plasma should be more than 20%. On histopathological examination, plasma cell along with Rolex formation of RBC is seen. So this is all for today, and if this video was helpful, then please do like and subscribe my channel. I will see you in the next lecture. Thank you.